arthroscopic posterior labral repair in traumatic recurrent posterior sublaxation, long midterm 2 to 5 years follow. So the posterior dislocation of shoulder is a rare entity, account to 2% of all dislocations. Most often occur during the seizures and high energy trauma. Most posterior shoulder instability has been shown more recently, have been more common actually previously thought. Patients typically present with a variety of symptoms, mainly pain. The signs of instability is often non-specific, and complete dislocations does not occur very common. So MRI is a sensitive and radiological investigation for capsulolabral complex, and the posterior instability is difficult to manage. With very few studies has been come with the outcome. So our study is analyzes the outcome of the arthroscopic management in unidirectional post-traumatic posterior labral tears. So our aim is to evaluate the outcome of the arthroscopic posterior capsulolabral repair in patients with unidirectional traumatic posterior instability. So our inclusion criteria were traumatic, unidirectional posterior instability. Our exclusion criteria were atraumatic instability, multidirectional or habitual sublaxators or associated any lesions. So it is a prospective study conducted from July 2011 to 16 at Sri Ramchandra University. So the included patients underwent clinical radiological investigation and proceeded by arthroscopic posterior labral repair by a single senior experienced surgeon. All patients were followed at regular intervals, and a UCLA scoring system was adopted to evaluate the outcome. So it was a standard surgical procedure done under general anesthesia in a patient lateral decumbent position, operated in the patient in a hydraulic spider traction system. The portals used were the posterior, anterosuperior, anteroinferior, and the posterior inferior portal, that's the 7 o'clock portal. So the torn posterior labrum is identified and it is elevated, and the rasping of the glenoid surface is done. The anchors, or single loaded anchor is placed. So the labral bite is taken. The final that is the final labral repair, and the further if a second anchor is used, and the repair is completed. This is a surgical picture where is identified and elevated, and rasping is done, and followed by once reduction we will place the anchors, then the labral repair is done. So it's one of the few clinical cases. So then comes the result. The study period is from July 2011 to 16. So total of 33 patients were evaluated. 30 of them are male and 3 was female, and 28 was right-handed and 5 shoulders was left-handed. All the outcomes were evaluated under UCLA score. So finally the mean post-operative score which showed an excellent, that is 31. So this was the final result, where 85% of the patients had an excellent outcome, and 9 has good and 6 has fair. So the posterior instability being an uncommon and difficult to manage, with few studies to determine the outcome of the arthroscopic treatment when compared with the anti-instability. Various soft tissue and bony procedures for the treatment of posterior instability have shown high morbidity. So our study is one of a few studies to determine the outcome of the arthroscopic repair of for the traumatic posterior capsular repair. So our study is comparable with Michael et al. And Joseph et al., where they had a pre-op of 26.6 and ours was 24.2 scoring, and the post-operatively ours was comparable with them, which had a 31 score was 31. So to conclude, so the arthroscopic posterior labral repair in a symptomatic traumatic posterior shoulder dislocation or subluxation is a common dependable surgical option. Higher degree of suspicion and appropriate imaging is required to identify the posterior labral tears. So the good labral repair and rehabilitation can help the patient to attain the pre-injury level. So thank you.
Thank you very much. Well done. Finished in time. Questions? Yes, sir.
Just clarify to me your diagnostic criteria. Were they posterior dislocation and subluxation, or they were just painful shoulder and you could detect a posterior jerk sign?
No, a positive posterior jerk sign.
and not dislocation. You can't call it dislocation.
No, it was mostly sublaxation.
No,
Sublaxation.
the topic itself says recurrent
Sublaxation.
posterior subluxation.
Sublaxation.
In the conclusion, I saw dislocation and subluxation.
Sorry, sublaxation.
And
It's
did the
subluxation.
patient present with subluxation as a symptom or painful shoulder as a symptom?
So both. Most people came with the pain, mostly with pain, and some people came with the subluxation also.
Okay.
What was the, anybody else? What are the majority of the patients' trauma was? You said recurrent traumatic subluxation.
Yeah, everyone is traumatic.
What trauma?
So most people had most sports people, they had a slip and fall and some, sorry,
Okay, carry on.
a slip and fall, and some we had some 2 or 3 boxers who had symptoms, boxing activities and this thing.
So after 32, 2 or 3
Two-
boxers and the rest were all fallen
Or just slip and fall.
Yeah. Dr. Khalid?
Well done. I may have missed it, but this is a prospective paper, prospective, correct? And you recommend a labral repair as a reliable operation. Were there patients who had successful non-operative treatment? Can you recommend operative treatment over non-operative treatment? How about non-operative treatment? Have you got any experience with that?
Yeah, we have to evaluate the MRI very carefully, and clinical examination is very important to assess the subluxation.
How many of them were epileptics? Of the
Sorry?
30? How many of them were
So
epileptic?
only it's a traumatic, mostly a traumatic.
Okay.
Uh,
If there's no other questions? Ram? Yeah. Hang on. Thank you very much.